Thank you for joining this evening. My name is Julie Kavanagh, and together with Julie Hamilton Elliott, we make up the cardio team at Northern Ireland Veterinary Specialists. So I did my veterinary degree at Dublin and spent 2 years in first opinion small animal practice before deciding to specialise. I then did a rotating internship followed by a cardiology internship at a large private referral hospital near London called NiVS Veterinary Specialists. I then completed my cardiology residency at the Royal Veterinary College and obtained the diploma in cardiology in 2019. So this evening we will be focusing on conditions that cause incompetence of the mitral valve and therefore result in mitral murmurs. We'll start with an overview of the anatomy and function of the mitral valve, the specific features that indicate a murmur is of mitral origin, and why incompetence of the mitral valve is so important. We'll then review the different diseases that result in mitral incompetence, with a particular focus on their preclinical aspects, as this is an area which has changed dramatically over the past number of years. So I'd like to begin with a quick recap of the normal pathway of blood flow through the heart. Deoxygenated blood is drained from the head, neck, and thoracic limbs by a network of veins that will subsequently form the cranial vena cava. And in a similar manner, veins draining the thorax, abdomen, and pelvic limbs ultimately join the caudal vena cava. Both cranial and caudal vena cava enter the right atrium. During diastole, the tricuspid valve opens and blood fills the right ventricle. Then during systole, the tricuspid valve closes and the pulmonic valve opens, and blood is pumped to the lungs via the pulmonary artery. Oxygenated blood then returns to the heart via the pulmonary veins, which enter the left atrium. During diastole, the mitral valve opens and the left ventricle fills with blood. Then during systole, the mitral valve closes and the aortic valve opens. Blood is then pumped to the whole body via the aorta. So focusing in on the mitral valve, there are 6 components to the mitral valve apparatus. The posterior left atrial wall, the mitral valve leaflets, the mitral valve annulus, which is the hinge points of the valve leaflets, the chorda tendineae, the papillary muscles onto which the chorda tendineae join, and the associated left ventricular wall. Like humans, cats and dogs have 2 mitral valve leaflets. The larger is the anterior or septal leaflet, and the smaller is the posterior or mural leaflet. So grossly, a healthy mitral valve appears smooth and glistening. In this specimen, the left atrium has been removed and there's just a little portion of the left auricular appendage remaining here. The forceps are grasping the larger septal leaflet of the mitral valve, and we can see its attachment to the papillary muscle via this network of chorda tendineae. We can also appreciate how thick the wall of the left ventricle is, and this is because the left ventricle pumps blood to the whole body against a systemic vascular resistance of around 120 millimeters of mercury. The right ventricle, which simply pumps blood to the lungs, works against a pulmonary vascular resistance of around 30 millimeters of mercury, so the wall of the right ventricle is much thinner. At a cellular level, a healthy mitral valve has 4 distinct layers. The atrialis, which comprises a thin layer of endothelial cells. The spongiosa, which contains proteoglycans and glycosaminoglycans. The fibrosa, which contains collagen that continues into the core of the chorda tendineae. And the ventricularis, which is another endothelial layer that also covers the chorda tendineae. So the mitral valve should open during diastole, so the left ventricle can fill with blood without any restriction to inflow. During systole, it should close and form a perfect seal so that all of the ejected blood is directed forwards through the aorta and a one-way system is maintained. If we have an issue with the opening or closing of the mitral valve, this will cause turbulence in blood flow, which will result in an audible heart murmur. So when you describe a heart murmur, 3 elements are required: its grade, its location, and its timing within the cardiac cycle. Like all murmurs, mitral murmurs are graded on a scale of 1 to 6 based on set descriptions as provided here. It is really important to standardize the grading system in order to track progression, especially if you're working at a multi-vet practice where different people are auscultating at different time points. The way that I like to remember this system is to memorize that a grade 3 murmur is when the murmur is of the same intensity as the underlying heart sounds, and that a grade 5 is when you can palpate a precordial thrill, as I think it's easy to work the others out from there. So when you describe the location of a murmur, you are essentially saying over which part of the heart you hear it loudest. Mitral murmurs commonly radiate widely, and you may hear them on the right side of the chest too, but the point of maximum intensity tends to be at the left apex. And if you consider the location of the mitral valve within the chest, this makes sense. The mitral valve closes at the start of systole, and this causes our first heart sound, S1. Blood is then ejected via the aorta. The aortic valve closes at the end of systole, and this causes our second heart sound, S2. Therefore, a murmur occurring between the first and second heart sounds is one that is occurring during systole and is described as a systolic murmur. If we're hearing a murmur over the mitral valve during systole when the valve is supposed to be closed, the source of that murmur is mitral regurgitation. During diastole, which occurs between S2 and the following S1, the mitral valve should be open, allowing the left ventricle to fill. If there is restricted opening of the valve, restricting the inflow of blood, we'll hear a diastolic murmur, which indicates mitral stenosis. But without a doubt, the most frequent murmur in dogs is a left apical systolic murmur. And from this, we can immediately tell an owner their dog has mitral regurgitation. So we don't need an echo to do this. So what is the clinical significance of having mitral regurgitation? Well, that's very much dependent on the volume of the regurgitant jet. So when the volume is moderate to severe, this will lead to progressive dilation of the left atrium, as it will have to expand to accommodate the surplus blood. At the same time, the blood flow out of the aorta in systole, which is the stroke volume or the cardiac output, is reduced, because essentially more blood is going backwards than forwards. The baroreceptors in the blood vessels will sense this decrease in systemic arterial blood pressure, and the kidneys will sense a decrease in blood flow. Baroreceptors respond by triggering activation of the sympathetic nervous system, and this attempts to restore the cardiac output by increasing the heart rate, increasing the contractility, and causing a systemic vasoconstriction. And initially, this will improve the cardiac output, but the receptors involved in this response are rapidly downregulated, so the effect is short-lived, and a longer-lasting mechanism of improving the cardiac output is then required. And that's where the Renin angiotensinaldosterone system, or the RAS system, comes into play. So both hypoperfusion and sympathetic stimulation trigger the release of renin from the juxtaglomerular cells of the kidney. And this initiates the RAS system, with increased production of angiotensin and aldosterone. And the ultimate effects of the RAS system are to retain sodium and water and therefore expand the blood volume, and to cause a systemic vasoconstriction to improve the blood pressure. So this expanded blood volume and vasoconstriction increases the pressure with which blood returns to the heart, and that's also called the preload. The left ventricle will then have to dilate to accommodate the increased preload. And this extra volume of blood in the left ventricle compensates for the leak in the mitral valve and allows the cardiac output to return towards normal, but unfortunately now at the expense of a very remodeled heart. So eventually the heart can dilate no further, and the increased preload, together with chronic severe mitral regurgitation, will lead to elevated left atrial pressures. And as the pulmonary veins are then attached to a high pressure chamber, blood is going to struggle to move into the left atrium from the pulmonary veins, and essentially we'll get backup and congestion of the pulmonary veins. So when the pressure inside these pulmonary veins reaches a critical value, which is around 25 millimeters of mercury, where normal is around 10, the fluid component in blood will be pushed out of the pulmonary veins and into the surrounding interstitium and alveoli. And this is what is termed left-sided congestive heart failure or cardiogenic pulmonary edema. Now, as the area for gas exchange is now compromised, immediate intervention will be required. So congestive heart failure is probably the most frequent negative outcome for animals with mitral regurgitation, but there are other complications to consider. So dogs with mitral regurgitation can develop pulmonary hypertension. So this describes elevated blood pressure within the pulmonary circulation, and that can occur anywhere between the right ventricle and the left atrium. The elevated pulmonary venous pressures that accompany mitral regurgitation can lead to what is called a post-capillary pulmonary hypertension, and this is something that we are recognizing more and more frequently. Pulmonary hypertension can occur at any stage of left-sided heart disease, and it can be asymptomatic or potentially can cause clinical signs such as coughing, exercise intolerance, and syncope, and in extreme cases, right-sided congestive heart failure. Echocardiography is needed to diagnose pulmonary hypertension, and specific treatment is now available with a pulmonary vasodilator called sildenafil. Dogs with mitral regurgitation are also at risk of arrhythmias, particularly supraventricular arrhythmias, so those that arise above the AV node. This is most likely due to atrial dilation and remodeling that comes along with mitral regurgitation. Atrial fibrillation is a common complication for dogs with left atrial enlargement. And this is a fast, chaotic rhythm, and it requires specific treatment to slow the ventricular response rate. Atrial fibrillation can worsen symptoms of left-sided congestive heart failure and can destabilize a dog that was stable on medications, but it can also cause symptoms of right-sided congestive heart failure, such as ascites. Failure to adequately manage atrial fibrillation in addition to the underlying disease will dramatically worsen the outcome for that patient. So we've touched on the major consequences of having mitral regurgitation. So now we'll take a step back and consider the underlying form of heart disease that has led to the development of mitral regurgitation. So this is important because the treatment and prognosis will vary depending on the underlying cause. Fortunately, there are only 4 differentials to remember: myxomatous mitral valve disease, infective endocarditis, and mitral valve dysplasia are all conditions which directly affect the mitral valve and therefore cause a primary mitral regurgitation. whereas a disease of the heart muscle can result in a secondary mitral regurgitation, and we'll discuss that further in a moment. So the most common cause of mitral regurgitation is myxomatous mitral valve disease. So this disease has many names, so keep in mind that terms such as degenerative mitral valve disease and endocardiosis are actually all describing the same thing. This is the most common form of acquired heart disease, meaning one that a dog was not born with but has gone on to develop. And despite its name, actually any heart valve can undergo myxomatous change, not just the mitral valve. So back at the beginning, we talked about the cellular layering of a normal mitral valve. Well, myxomatous disease results in a disruption of these layers. So the majority of changes occur within the two innermost layers, the spongiosa, which expands, and the fibrosa, which degenerates. So this results in a reduction in both the quantity and quality of collagen within the valve leaflets and within the chorda tendineae. And the resulting gross changes to the valve include thickening and distortion of the valve leaflets and elongation or even rupture of the chorda tendineae. So we can appreciate how different this valve appears compared to the earlier specimen of a healthy mitral valve. And as a result of these structural changes, the mitral valve can no longer seal during systole, and the result is mitral regurgitation. So the incidence of myxomatous mitral valve disease is strongly associated with age and breed. It is a disease of middling to older age, and actually over 90% of small breeds over 8 years of age have evidence of myxomatous change to their valves. The Cavalier is often considered the poster breed for this condition, but contrary to previous beliefs, Cavaliers actually don't have a worse form of this disease, they simply develop it at a younger age. And so while this disease is a slowly progressive condition over a number of years, cavies are likely to live long enough with it to become symptomatic and experience the complications that can arise. Other overrepresented breeds include Chihuahuas, Dachshunds, Shih Tzus, and Yorkshire Terriers. And whilst not common, some large breeds, such as the German Shepherd, can also be affected by myxomatous mitral valve disease, and their progression tends to be more rapid. In order to standardize the diagnosis and treatment of dogs with myxomatous mitral valve disease, the American College of Veterinary Internal Medicine has devised a staging system. So dogs that are currently healthy without a heart murmur, but are of a breed that has an increased risk of developing myxomatous mitral valve disease, are considered stage A. Stage B dogs have myxomatous mitral valve disease, so will have a mitral murmur, but whilst they have heart disease, they do not have heart failure, and they are still asymptomatic. Stage B subdivides into those with a normal heart size and shape, stage B1, and those in which there is evidence of cardiac remodeling, and these are stage B2. Stage C then describes dogs that have current or previous clinical signs of congestive heart failure, so typically dyspnea or tachypnea due to pulmonary edema. And stage D dogs are those which have become refractory to the standard treatment for congestive heart failure. And this is defined as requiring a total daily dose of furosemide that is over 8 milligrams per kilogram, in addition to the standard doses of pimavendin, ACE inhibitors, and spironolactone. So any dog with a mitral murmur from suspected myxomatous mitral valve disease can benefit from referral to a cardiologist. For those who are asymptomatic, so your stage Bs, advanced echocardiography can confirm the underlying disease, can most accurately determine cardiac dimensions to stage these patients as B1 or B2, and can even estimate proximity to congestive heart failure. Concurrent complicating conditions, such as pulmonary hypertension, can also be readily identified and addressed. Our primary reason to investigate these asymptomatic myxomatous mitral valve disease cases is that we now have strong evidence that early intervention for those with cardiomegaly is beneficial. The EPIC study, which was published in 2016, was a randomized clinical trial in which dogs with stage B2 myxomatous mitral valve disease were randomly allocated to receive either pimobendan or a placebo. And those in the pimobendan group took on average 15 months longer to develop symptoms of congestive heart failure when compared with the placebo group. This study was actually so successful that they stopped it early. So it was such a clear beneficial effect that they quit halfway through. So for your stage C or D patients, those with either current or previous clinical signs of congestive heart failure, a cardiologist can ensure medical therapy is optimized, resulting in the best outcome for that patient. So whilst congestive heart failure may have previously been considered a terminal event, with appropriate input and follow-up, many dogs continue to experience a good quality of life for upwards of a year following the onset of pulmonary edema. And this is really comparable to chronic kidney disease, and so euthanasia should not be immediately recommended. Our next two conditions resulting in primary mitral regurgitation are relatively rare. Infective endocarditis describes a bacterial infection involving the valve apparatus that results in the formation of these cauliflower-like lesions, and these are called vegetations. These lesions interfere with valve function and result in mitral regurgitation. So the aortic and mitral valve are most commonly affected in small animals. Infective endocarditis should be high on your list if you hear a new mitral murmur in an animal that has recently been unwell. So particularly if they've had a reason to be bacteremic, such as a recent dental procedure or a urinary tract infection. It is much more common in large breeds, and often they will be pyrexic. If you are suspicious of infective endocarditis, referral as an emergency is recommended. Mitral valve dysplasia is a congenital form of heart disease, and it describes a mitral valve that is malformed. So this can actually take many forms. In this example, the mitral valve leaflets insert directly onto the papillary muscles, and the chorda tendineae are absent. You should suspect mitral valve dysplasia when you detect a mitral murmur in a young dog. As a dysplastic valve can be regurgitant, stenotic, or both, you may hear a left apical murmur that is systolic, diastolic, or indeed both. English Bull Terriers and Labradors are overrepresented for this condition, and as with any puppy murmur, these cases should be referred quickly for assessment. And finally, we come on to myocardial diseases, so disease of the heart muscle as opposed to the heart valves. And the most common form of this disease in dogs is dilated cardiomyopathy, or DCM. So the normal myocardium is composed of specialized striated cardiomyocytes, which have the ability to shorten or contract upon an electrical stimulus. And these cells are surrounded by structures called intercalated discs, which allow communication between cells and allow them to act as one unit. With DCM, the ability of the cardiomyocytes to contract is impaired. So we don't fully understand why this happens. In cats, there was a strong link between diets that were deficient in taurine and the development of DCM, so people naturally suspected a similar link in dogs. But with the exception of certain breeds, such as the American Cocker Spaniel, most cases of DCM in dogs do not appear to be associated with taurine deficiency. Recently, there has been a lot of attention surrounding grain-free diets and DCM. Like with taurine, this is not proven, but I have seen a few unusual breeds develop DCM that were fed a grain-free diet. As DCM has a higher prevalence in certain breeds, we know there must be a genetic component also. The myocardial changes on Histopath in dogs with DCM largely fall into two categories. So giant breeds tend to experience an attenuated wavy fiber type of myocyte degeneration, wherein the cardiomyocytes are atrophied and become surrounded by an oedematous fluid. Dobermans and boxers seem to have a different phenotype, whereby their myocardium becomes infiltrated by fatty tissue. So when the contractility of the cardiomyocytes is reduced, the left ventricle will respond by undergoing eccentric hypertrophy or dilation. And this will stretch the annulus of the mitral valve, meaning the valve leaflets no longer meet in the middle, and we get a secondary mitral regurgitation. Because the contractility of the left ventricle is impaired, the speed of the regurgitant jet will be reduced. And this means the mitral murmur due to DCM tends to be soft, so usually grade 3 or less. So like myxomatous mitral valve disease, DCM is a disease of middling to older age. Typically affected breeds include the Doberman Pinscher, giant breeds such as Great Danes, Dog de Bordeaux, and Dalmatians and Weimaraners. But keep in mind, we may see more unusual breeds given the trend to feed grain-free diets and this possible association with DCM. So the diagnosis of DCM can be really challenging. Typically, the parameters of systolic function will be reduced and the cardiac dimensions will be increased. But it's important to remember that other factors can affect these measurements, such as the breed of the dog, the activity levels, and any concurrent conditions such as hypothyroidism. It's also good to be aware that other cardiac diseases can produce a DCM phenotype on echo. So for example, a long-standing uncorrected PDA will cause the same changes on echo as DCM. So because of this complexity and the vast variation in treatment and outcome depending on the underlying cause, again, referral to a cardiologist is recommended if you suspect or want to screen an animal for DCM. So dogs that meet the criteria for DCM but are still asymptomatic, so haven't experienced congestive heart failure, are termed preclinical or occult. And they can actually remain in this stage of disease for years. The PROTECT study, published in 2012, investigated the effects of pimabendin on Doberman Pinschers that had occult DCM and found a marked survival benefit compared to those that were receiving a placebo. So extrapolating from this, any dog with occult DCM and structural changes on echo should start treatment with pimabendin. So given the evidence we have for early intervention with pimabendin, I suppose it might be easy to conclude that all dogs with a newly detected mitral murmur should start on it, particularly if the owner declines further investigation. But that wouldn't really be recommended for two main reasons. So one is the cost. Preclinical myxomatous mitral valve disease and DCM can last for years. A year's worth of pimabendin for an average size cavie is about £600. Considering a consultation and echo at NiVS is $500, it really is a false economy to blindly treat. But even more importantly than that is that the studies that display a benefit of the early therapy with pimobendan have all included dogs with a remodeled heart. So we don't know if introducing Pimo ahead of this would actually be detrimental. And one small study in 2007 involving dogs with very mild myxomatous mitral valve disease demonstrated a worse outcome for those receiving Pimo. So therefore, it should only be recommended once an accurate diagnosis and an estimate of heart size is obtained. So I guess my take-home message is that mitral murmurs are extremely common. I guarantee you will find at least one this week. And even if the patient is asymptomatic, we should be encouraging further workup because the correct diagnosis and early intervention can dramatically alter outcome. So we are very happy to see these patients at NiVS if you're based in Ireland, or to provide advice or guidance if needed. Julie and I also work for a telecardiology service called Vet Oracle, and we offer advice and interpretation of echo, ECGs, and thoracic radiographs. We've also recently introduced a Holter rental service. So please feel free to get in touch if we can be of any help. Thank you for listening, and I'm very happy to take any questions you may have on the mitral valve. Okay, so I've got a couple of questions. Let me just read them first. So the first question is, how soon after a dental procedure would infective endocarditis occur? Should we be routinely checking for new heart murmurs after dentals? So a great question. I would imagine probably around 3 to 5 days post-dental is when you might be expecting endocarditis to appear. I wouldn't say it's very common, and certainly a dog that has something like myxomatous mitral valve disease isn't at any increased risk of developing endocarditis. However, dogs with subaortic stenosis, so typically boxers, are predisposed to developing endocarditis. So if it was a boxer, I probably would encourage seeing it back maybe a week or so after to check up on it. Otherwise, I would say probably not something that needs to be done routinely because it's not very common. But I guess if the owner came back in saying, you know, he's very off form, he's not himself, and you find pyrexia and a murmur, certainly alarm bells should be ringing. So the next question is, how often do you see pulmonary hypertension in asymptomatic cases of myxomatous mitral valve disease, maybe in stage B2? So again, a really good question. So I would say certainly it's more common with stage B2 and C because they are animals that have pulmonary venous, increased pulmonary venous pressure. So it makes sense for those animals to develop pulmonary hypertension. Occasionally we do see it in a dog that hasn't any cardiac remodeling, so a stage B1. And it's possible that they have a concurrent condition that results in pulmonary hypertension. So they could have a pulmonary fibrosis or bronchitis or something else that's triggering it. So I'd say definitely more common in stage B2, C, and D, but not impossible in an earlier stage, and certainly something that the sooner you can identify and treat, the better the outcome will be, because we know it's a negative prognostic indicator for a dog with myxomatous mitral valve disease to also develop pulmonary hypertension. So really good questions. So we've got one more coming through. So if an owner won't go for referral for echo, is a thoracic X-ray still beneficial? Is a large VHS enough to start on pimobendan? So I guess I would say that radiographs, I mean, absolutely, if referral is not an option, of course, some way of measuring heart size is worth doing. I think that radiographs can vary dramatically from breed to breed. So I've had several referrals from animals that on radiographs seem to have an enlarged heart, and I would agree with that, having seen the radiographs myself, but on echo, actually, they measure normal. So I would say that they're not the most reliable, but certainly better than nothing. I would encourage that you look at breed-specific VHS if you can find it, because they do exist for various breeds, because what's normal for a little Yorkie mightn't be normal for a bigger dog. So certainly worth looking at breed-specific VHS if you can find it. One more thing to mention is that there is another paper that has been released a few years ago describing essentially a left atrial VHS, so a way of sizing the left atrium, which is called the, I think, vertebral left atrial scale, the VLAS. And I would encourage looking at that paper because it's quite helpful as well to give you kind of more backup that the left atrium is enlarged and justify your decision to start pimobendin. Without a doubt, echo alone would be better than x-rays alone. But certainly if it's not an option, it's a way of evaluating heart size. So I wouldn't discourage it. So I think there's another question. So would a course of antibiotics treat infective endocarditis? Does it cause permanent damage to the mitral valve? So I guess ideally you would want to do a blood culture before starting antibiotics to give you the best idea of knowing what infection it is you're treating. If you start antibiotics and then try to do a blood culture, often it's negative, even though there actually is a bacterial infection there. So obviously you would culture and then you would base your antibiotic choice based on sensitivity, based on a culture and sensitivity profile. The damage caused to the mitral valve can be permanent. So even if they survive the initial infection, the mitral regurgitation they're left with can lead to trouble. So your congestive heart failure, pulmonary hypertension, whatever. I would say it is a difficult disease to treat. Certainly, serial echoes every day would be useful. So that's why I would say the best chance that dog has of surviving would be going to see a cardiologist where it can have that level of input. Certainly the prognosis with aortic endocarditis is really poor. I think there's another one. So Kerry, hi Kerry. Kerry asks, do you use ProBNP and what are your thoughts on it? I guess I don't use it that often, but that's because I can echo. So obviously, if you can echo, that answers the questions that ProBNP would answer. So ProBNP is released when you get stretch of the heart muscle. So it makes sense that an animal undergoing cardiac remodeling would have a higher ProBNP than one that still has a normal heart size and shape. I would say if echo isn't feasible, it's a good place to start. If it's elevated, I still would encourage the owner to go for a referral or at least have an echo rather than starting treatment based on ProBNP alone, because obviously it's not foolproof. So I guess you can use it maybe as a way of encouraging further workup. If it's normal, it's very likely that this animal is very early stages of say myxomatous mitral valve disease, so unlikely to need further input. But probably using it as an initial investigating tool is a good idea. Okay, thanks very much.
Bye-bye.
Bye.